Okay, I'm going to try to go ahead and just record this lecture, The Infertility. Alright, we already went through part of this stuff, the traditional definition being the inability to conceive after 1 year of regular unprotected intercourse. However, the modern definition and what most people tend to think of when they say they're infertile is the inability to conceive whenever it's desired. So we also have two types of infertility, primary infertility and secondary infertility. Primary infertility, the couple is unable to conceive after, hopefully you got this information from lecture itself, but if you didn't, hopefully you'll look through the book first. But the unable to conceive after 1 year of unprotected intercourse. And then secondary is when the couple is unable to conceive a second time after one successful pregnancy. We also have a type of secondary infertility that's with unsuccessful pregnancies where the couple conceives but they suffer repeated miscarriages. So, seeking infertility help because of delayed childbearing, we are now delaying childbearing into our mid to late 30s, and that's when the natural decline of infertility, or the natural decline of fertility occurs physiologically anyway. And then we have now new treatments. It's caused couples to reconsider initiation of treatments for infertility. The assumption of infertility. So most couples assume they're fertile and spend many years trying to not get pregnant. So they spend a lot of time trying not to get pregnant. And then when they don't get pregnant in a few months, they really start to doubt their fertility. Psychological reactions to infertility are significant. So we've got shock, that's the first reaction. Guilt, the partner with the identified problem may feel guilty, or they may have guilt over past sexual experiences that may now be affecting fertility, or a past elective abortion or something of that nature that's now they think may be affecting their current fertility. Isolation, they feel different from other couples with children. Depression, infertility challenges that sense of control and self-image. It's this roller coaster of hope and despair. And it causes a lot of stress on relationships. So they may feel unloved because their self-esteem is shaken. Intercourse often becomes more of a job rather than love. And we talked about in class, they have, you hear about people all the time who have decided that they can't get pregnant, so they decide to stop trying, and they decide on adoption. They go forward with the adoption plans, and that's when they get pregnant, when they're no longer trying to get pregnant. That's stress. All right, culture. Culture and religious considerations. Infertility often means that it's the male or female's problem in many cultures. So again, hopefully you're looking these up if you don't know them, but infertility often means it's a female problem in many cultures. It can be linked to the woman's social status. Treatment may mean going against societal norms. Religious norms influence tests and treatment options. And conflict when treatment is acceptable to one member of the couple but not to the other. And that's significant. One person may agree to do one type of treatment plan, the other partner doesn't want to do that treatment plan, and that causes a lot of issues. All right, we have many different factors affecting fertility. With male infertility, or factors for the male would be abnormal sperm, abnormal erections, abnormal ejaculation, and abnormal seminal fluid. And this was all discussed in the presentation. I can't remember which group did it, but we had a group presentation on this and they did a good job. So let's start with abnormal sperm. The sperm must be deposited near the cervix. They must be protected from the acidic vaginal secretions. They must enter the cervix, swim to the ovum. It's a lot of work. Okay. The man may have a low sperm count. He may have weak or abnormally formed sperm. Abnormal sperm issues in the fact that it may interfere with the normal sperm. These types of things may interfere with the normal sperm formation. If we have high scrotal temperature, so hot tubs, tighty-whities, varicoceles we talked about the other day. Well, that's under anatomic anomalies on here. But it causes a smaller testicle as well as an increased temperature with all that blood flow. We've got abnormal hormones, infections, medications, illicit drugs and alcohol, and different exposures to toxins can all affect sperm formation. All right, abnormal erections. anything that impairs the nervous system function or the blood flow to the penis, and other causes for abnormal erections are medications such as antihypertensives and other medications. Then we have abnormal ejaculations. We can have a retrograde ejaculation where the semen is released into the bladder rather than from the urethra. We've got the hypospadias. This is where semen is deposited closer to where, so here's a picture of a hypospadias, and this is the opening. Instead of it being at the tip of the penis, it's down here. So physiologically, this means now that the semen is going to be deposited closer to the vaginal outlet rather than near the cervix where it needs to be. We've also got, we could also have abnormal seminal fluid. Seminal fluid carries the sperm into the vagina, but only sperm actually enters the cervix, not the fluid. The semen coagulates immediately after ejaculation and liquefies within 30 minutes for the sperm to be able to swim. The seminal fluid can't remain thick and must protect the sperm from what? Has to protect the sperm from the acidic vaginal secretions. All right, then we've got female factors for infertility. So female reproduction, female fertility depends on regular production of normal ova, the path from the ovary to the uterus, and the endometrium or the endometrial lining that's enough to support the pregnancy. So we can have disorders of ovulation, abnormal fallopian tubes, abnormal uterus, cervix or ovaries, and hormonal abnormalities. So we'll break those down. So disorders of ovulation. Ovulation is balanced, timed interaction between the hypothalamus and what other two areas? Again, hopefully you'll take the time to look these up, but it's between the hypothalamus, the pituitary, and the ovary. All right. Causes that can cause disorders of ovulation would be chemo, excessive alcohol, smoking, menopause, amenorrhea, just to name a few. Polycystic ovarian syndrome or PCOS, and hormonal disorders. All right, we can have abnormal fallopian tubes with pelvic adhesions. These result in a blockage of the tubes. This can be caused from infections such as chlamydia and gonorrhea. Endometriosis, where that uterine lining tissue grows outside of the uterus, could occur from pelvic surgery. Appendicitis or any other prior pelvic inflammation. Peritonitis, which was inflammation of the lining of the abdominal wall, and ovarian cysts. So you can see the difference here in this normal uterus and this endometrial. I mean, look, everything just looks so much bigger, redder, inflamed, irritated. Okay. All right, abnormal uterus, cervix, and ovaries. We've got congenital abnormalities of the reproductive tract. We can have uterine myomas. These are benign uterine muscle tumors. We could have PCOS, polycystic ovarian syndrome. You could have uterine fibroids, polyps, or adhesions that would cause problems getting pregnant. And some women actually develop antibodies against sperm. All right, we've got abnormal hormones. These will be hormones that would interfere with ovulation. They interfere with the proper uterine lining development if our hormonal balances aren't just right on. Abnormalities in the amount or timing of the necessary hormones for the endometrium, the ovum, and the endometrial lining to be ready for ovum development and release, and then support of conception. So other factors that can affect fertility is the couple's history. Coital frequency, we talked about that a little bit earlier. Coital frequency, age, smoking, exercise, diet, weight, emotions, medical issues, and drugs and chemicals. So these are all very important factors for both couples, both parties involved, that can significantly affect fertility. So coital frequency, they should be having intercourse 3 or more times a week if they're trying to conceive. So those people who I think I mentioned in class, if they say, yeah, we've been trying to get pregnant for a year, we'll have to having sex like once a month. Okay, not happening. Okay, so we have to evaluate the coital frequency. It needs to be at least 3 or more times a week if they're trying to conceive. Age, goes into play. Decreased fertility for women after age 35. Smoking plays a part. If they have 15 or more cigarettes per day, it suppresses their immune system, which leads to a loss of the reproductive function. Can have an increased risk of ectopic pregnancies as well as smoking related to the decreased tubal motility. Okay. Exercise, diet, and weight, emotions, and medical issues. So exercise, if we have excessive exercise and weight loss, we have decreased fertility because we may have the amenorrhea. Low-calorie diets, excessive weight loss. Then we have the other problem on if we have obesity. We can have ovarian dysfunctions with the actual releasing of the eggs. Emotion doesn't cause infertility per se, but it causes increased stress and anxiety, which then does play a role in fertility. So just as I was describing about women or couples who finally decide, we're going to adopt, this isn't working, it becomes a job, it's very stressful, and they decide to adopt, or just they're not going to try this month, that's when they tend to get pregnant. And different medical issues. So we can have the woman can have things like pelvic adhesions from different surgeries, Crohn's disease, ulcerative colitis, celiac, pelvic inflammatory disease, and STIs all factor into your fertility. Then we've got drugs and chemicals. So chemo drugs are obviously very detrimental to all the cells in the body. And they actually now have these ova storing during treatment. So if you have been diagnosed with cancer, they can actually store your eggs, and they can actually store your sperm as well for a later time. And so I read a story, it's been a little while, about a young man who, when he was much younger, had some type of cancer. And so his parents, as a younger child, his parents stored some of his sperm before he started chemo and cancer treatments. And he was later on, he survived the cancer treatments as a 20-something-year-old. They were able to utilize that sperm that his parents had saved. So, it's sad to think about, but it's something you want to think about, and the options are there, and it is available. All right, recreational drugs cause infertility. Antihistamines, we've talked about before, they decrease the vaginal lubrication. And NSAIDs block egg release. All right, infertility evaluation. What are we going to do to evaluate infertility? So for the males, we're going to do a semen analysis. We're going to test the sperm's motility, how fast they move, how well they move, the number of sperm that are released. We can do endocrine tests to test their hormonal levels. We can do ultrasonography, so an ultrasound to identify anatomical issues. And we can do testicular biopsy to analyze the testicular tissue for any issues. Female testing, we may look at the family planning methods, ultrasonography to identify maturation and release of the ovum to make sure she is ovulating and releasing eggs, endocrine testing to identify, again, hormonal issues. She can have a hysterosalpingogram. That's an x-ray that is taken to evaluate the reproductive organs. And we may do a hysteroscopy and laparoscopy to evaluate the interior uterine and pelvic organs. And I think they discussed that as well in their in the presentation that the group gave. So therapy for infertility. Therapy depends on the cause, if there is a cause. But we can do medications such as bromocriptine or Parladel. This medication stimulates ovulation. These are on page 272 in your book, and you're going to need to know these medications, okay? But bromocriptine or Parladel stimulates ovulation. Clomiphene or Clomid is one that induces ovulation. The woman's not ovulating, and this is one of the reasons why we now have these two, Parladel and Clomid. But Clomid in particular is used frequently has been a factor, I guess, in increasing the number of multifetal pregnancies, because we're inducing ovulation. Therefore, the woman is likely to release more than one egg at a time. Okay. Gonadotropin-releasing hormone, which stimulates ovulation in testosterone and sperm. We may do Leuprolide or Lupron, which decreases the endometriosis. Minotropin, which stimulates ovulation and sperm production.